So, good evening, everyone. Hello back after the feast vacation to our series of OCMO gynecological oncology didactics about gynecological cancers. And tonight it's our pleasure to continue in the ovarian cancer module. We have just started last week or the week before feast with Professor Rida Shouki speaking about the epidemiology, clinical presentations, and etiology of ovarian cancer. And today we have a very interesting topic to speak about, which is genetic aspects in ovarian cancer. It's very important, not only for the pathogenesis and for the diagnosis, but now it's very important too for the treatment. It's an honor and a privilege to have today a very important Egyptian oncologist, Professor Khalid Abdelaziz. He is a consultant of clinical oncology from Ain Shams University and my dear friend and brother. And he was humble enough to accept our invitation from OCMO to be with us today online to present about the genetic aspects of ovarian cancer. So, Dr. Khalid, the floor is yours.
Thank you very much, Dr. Basil. It's always an honor to be part of your educational activities. I know this topic is a quite heavy one, and we'll try to make it as simple as possible and as clinically oriented as possible, because at the end of the day, we want the information that is going to help us in our daily practice and management for ovarian cancer cases. So we're going to discuss quickly on the important aspects in genetics and biomarkers of ovarian cancer, specifically the PARP inhibition and its relation to homologous recombination deficiency. So the first questions we need to ask when we are going, what we need to answer during our presentation is, do we need to test for genetics mutations in blood, in tissue samples? What do we need to test for BRCA1 and 2 or other type of mutations? So this is the kind of report you see in your daily practice, specifically in Egypt, where you can see the type of testing that has been done and the conclusion giving you a score about the HRD status or the homologous recombination deficiency score, and a comment on the BRCA genes mutations that are the most important types of mutation, and its clinical or predictive value in terms of response to PARP inhibitors, as known as niraparib, olaparib, and other types of PARP inhibitors available in the market. So let's go through the basics. The basics says that we need to distinguish between the type of mutation, the phenotype test, and the type of test that we're going to use. So the type or the phenotype that we are looking for, we have, for example, the homologous recombination repair, HRR, which is a mechanism of repair of double-strand breaks, a very common type of mutation we have daily in our bodies. The homologous recombination deficiency is the mutation, or to be more specific, the phenotypic output from a mutation that affects the homologous recombination repair. So clearly, it is a homologous recombination deficiency, inability of our body, of our cells, or the cancer cells, to repair homologous recombination repair, whatever the mechanism of repair it is. And then this inability to repair this type of mutations will lead to multiple scars. When we have injuries in our skin, if this injuries does not repair in an efficient way, it will leave a scar. And the repeated effect of homologous recombination deficiency will lead to accumulation of scars called the genomic instability. And this is one of the ways to test for the effect of mutation, is to look for the genomic instability, or the quantity of scars you can see in the DNA. An HRD positive tumor is a tumor that has a number of scars that is high enough to be qualified as HRD positive, meaning that is going to benefit from a treatment called PARP inhibitors. So homologous recombination deficiency is not something specific to ovarian cancer. It is present in a lot of cancers in our body. And this is why the use of PARP inhibitors, although it has started specifically in ovarian cancer, yet it can be used nowadays. It is expanding in indication in other types of cancers, specifically breast, pancreatic, and prostate cancers, and it is increasingly investigated in other types of cancers because the homologous recombination deficiency is actually present in other types of disease. So the different types of DNA damage that we know from our basic science studies are the commonly known base the single strand breaks, which are usually repaired by base excision repair. And this is specifically where it is the base excision repair is based on the use of the PARP protein. This is the protein that helps in the repair of single strand breaks. And this is the main mechanism of action of the PARP inhibitors. So the PARP inhibitor are going to stop the base excision repair. We have other types of repairs like nucleotide excision repair, like mismatch repair. And then specifically for the double strand breaks, we have the non-homologous end joining, and we have the homologous recombination repair, HRR, that we have been talking about. So for double strand breaks, we have these two types of repair, but the standard one is the HRR, the homologous recombination repair, because the non-homologous end joining, because of its mechanism of repair, is prone to a lot of errors, leading to cell death and apoptosis. So if we have a deficiency in homologous recombination repair, and we know that non-homologous end joining is actually not very effective in repairing these double-strand breaks, the body will base its trial, the cancer cells or the body cells or whatever cells are going to try to fix it through base excision repair to fix each strand in a single strand break. And this is going to be the way of treatment by stopping the single strand break, so stopping any way of mechanism that the body or the cancer cell is able to repair the damage that has been done in the DNA. So if we have a normal cells and we have an efficient homologous recombination repair and other repairs are also working, like the base excision repair or other types, we have a survival of the normal cells if a mutation happens in the cells. If we have a normal cell that is affected by a treatment, specifically in our condition, the PARP inhibitors or the platinums, which is one of the drugs that cause a lot of double-strand breaks and affects its ability to repair also, then because we have an efficient homologous recombination, we have cell survival. In homologous recombination deficient cells, if we do not give any treatment and we have homologous recombination affection, if we don't give any treatment, we have a high probability also of cell survival. But when we have a cell that has homologous recombination deficiency and we target the other types of repair through, for example, the PARP inhibitors, this is the way which leads to synthetic lethality and cell death and apoptosis. So in ovarian cancer specifically, and why PARP inhibitors has gaining the most importance in ovarian cancer, because this type of mutation is very common. The first that we have known from the start of the analysis and genetic analysis of ovarian cancer was the BRCA testing, BRCA1 and BRCA2, they're very well known. And it can be either somatic, means it is only in the cancer cell, or it can be germline. It means that the patient has inherited this mutation from her mother or father, and has caused a cancer cells. So she has the mutation in her normal cells, in the bloodstream, and in the cancer cells. So whoever has a germline mutation, by default, has a somatic mutations. So when we say that we have a somatic mutation only, it means somatic mutation without a germline affection. And then with further studies, we discovered that we have other genes that are involved in the repair mechanisms, especially specifically in base repair, that can actually have a strong effect when targeted by PARP inhibitors in combination. Sorry, I'm sorry. We have a lot of other genes that are actually affecting the homologous recombination repair. So when affected, targeting again the other types of repair mechanism will lead to cancer cell death. Okay, so we know the most well-known are the BRCA genes mutations. Then we have other genes like CDK12, RAD51C, other types of genes that we know that leads to homologous recombination deficiency. And we have other genes like the P10 mutations that possibly may lead to homologous recombination deficiency, but we are not yet very sure of that. And then we have other types of mutation that are not prognostic or predictive of a treatment response. So how do we test for this HRD deficiency? So let's agree that BRCA1 and BRCA2 is one type of homologous recombination deficiency. The other types is having other genes, but the idea is the other genes alone are not by default, meaning that we have an effective and clinically effective homologous recombination deficiency. And this is why we had to look at our cancer cells in a different way. So either we look for BRCA1 and BRCA2 testing, or we can look at other types of mutation. So when we see that we have a BRCA1 and BRCA2 mutation, we know that we have a homologous recombination deficiency. And we can look at specific genes and know that we have certain types of mutations, but we are not always sure if this type of mutation we are going to predict response to PARP inhibitors or not. So other way of looking at the effect of mutations is to look at the scores, what we have been talking about, the genomic instability. And this is the HRD score. This HRD score looks actually at the number of scores that are in the DNA material of the tumor, and then gives a score about the quantity of these mutations. And having a score of 42 or more means a high probability to have a response to the PARP inhibitors. It means high probability to have a clinically ineffective homologous recombination, therefore a probability to stop any type of repair by giving a PARP inhibitors. So the HRR gene panel test, you can see you have the BRCA1 and BRCA2 that are very important, and then you have a lot of other type of mutations. And then you have other ways of looking at genomic instability test, like something called loss of heterozygosity, means the two chromosomes are not similar to each other's, or other types of instability like the allelic imbalance. It means the alleles are not similar to each other's. And the large scale state transitions, it means a lot of mutations transiting between one chromosome and the other. Looking for, the idea is that it's looking at a quantity of mutation that will lead to homologous recombination deficiency, and then will lead to the probability of responding to platinum compounds and PARP inhibition. So when we look at panels, large panels of mutation, we can actually test for BRCA1 and BRCA2. We can test for the different types of mutation, And also what we can sometimes see is the loss of heterozygosity and tumor mutational burden and microsatellite instability. But these are not validated as predictor to PARP inhibition by themselves, unless we find a BRCA1 and a BRCA2 mutation. So this can be seen by selective panel or a comprehensive panel like Foundation 1 testing, which is a known FDA-approved test from Roche. The other option is to look at the BRCA1 and BRCA2 and look at all types of instability tests or the scars that are in the DNA. And the other approved test for this is the Myriad MyChoice test, which is the FDA-approved test for prediction of response to a PARP inhibitor. And it is a predictive when we have a score of 42 or more. So we can either test for any types of DNA samples, either in a tumor, in the blood. In the blood, we look for germline. And sometimes you know that you can look for swabs when you do sometimes testing for Lynch syndrome or other types of germline mutations. And you can look for plasma for circulating tumor cells. It is some way of replicating somatic testing, like testing for the tumor, without having to biopsy the tumor by itself, but it's not, again, yet validated specifically for HRD testing. So the other important point is that when you test in the blood for germline mutation, you can get a high majority of the BRCA mutation, and you can get some more HRR mutations, but will not give you a specific clinical implication if it's going to be correlated with homologous recombination deficiency, clinically valid HRD. And then you can test for the tumor, where you can see you have a probability to detect more BRCA mutation. You have the ability to detect more HRR mutations. And the most importantly, you have the ability to look for the scar in the cancer cells and therefore be able to calculate the HRD score and be able to predict a response to PARP inhibition. What does this mean? It does mean that having a tissue that is well preserved and a good tissue biopsy is very important, because if you rely only on the germline testing, like some times our colleagues may do, you may be able to miss maybe 1/4 of your patients that could have been eligible for PARP inhibition. So the Myriad test, which is the one we use in Egypt and the commercially available worldwide for prediction to treatment to PARP inhibitors, looks at the tumor somatic BRCA mutations and looks at the scars, the genomic instability. So either it finds a BRCA mutant patient, and this is HRD positive, or it has a score of more than 42. And by default, whichever patient has a BRCA mutation has a score that is higher than 42. And this patient is eligible to receive a PARP inhibitor if she is platinum resistant. But this is, again, another lecture about the value of the tests in treatment selection. If this patient does not have a BRCA mutation and has a score of less than 42, then it is labeled as HRD negative, and the probability to respond to PARP inhibitor is very low. It is not nil, because we know that any tests we have in medicine has sensitivity and specificity percentages, meaning that we have sometimes false negative, meaning that some HRR mutations that did not cause enough scars to have a score more than 42 are still potentially responsive to PARP inhibitors by olaparib or niraparib or the common PARP inhibitor drugs that you know in the market. But again, this needs further studies, and we are not being able yet to specify which are these patients. Why do I say this? Because in a subsequent lecture, somebody is going to tell you that, for example, in the study of niraparib, it has shown some response in patients with HRNE negative disease. So this is the whole picture of important aspects of BRCA testing. I hope it has been answering the questions that we need, and I'm open if you have any question about this lecture.
So thank you, Dr. Khalid, so much for the concise and to the point presentation. I have to go back to my dear fellows and colleagues and say, was it clear for you? Would you like to ask some questions? Was it too heavy for you? I need first to hear Amira. And Amira, do you have any questions?
لا والله دكتور باسل, thank you very much. Dr. Khalid, nice to see you again. And the lecture was great. طبعا at the beginning I got a little bit confused, and I think I came up with a few things at the end, but I think I got the main idea. I need to read about it, maybe to get more details myself, يعني. But the big picture about use of PARP inhibitor and when to decide to use it and when not to, I got the main idea. It was very clear.
And again, this is, thank you, Dr. Amira, for your comment. Again, this is there is another definitely big lecture about the value and the use and the indication of PARP inhibitors. But the main idea of this topic was to focus on why we test, how do we test, and what is the relevance of each test alone. So if you test for BRCA1, sometimes, because we see sometimes colleagues that test only for BRCA1 and BRCA2, so you know you are missing a lot of patients. We see that sometimes colleagues are testing with non-validated tests, so we know that it is not the standard of care for testing for these patients. You can see sometimes that they test only on blood. So you know that testing on blood, you see only the germline mutations, and you may miss some of your patients.
Okay, yes.
So we have another question from Dr. Radwa from UK. Dr. Radwa, the mic is yours. Please unmute yourself, Radwa.
Can you hear me?
Yes.
Yes, hi. Thank you so much, Prof Khalid, for the concise lecture. Actually, my question was the indications which you stated that you're going to cover it later. I just don't know if there is a room or what is going on with HDR positive patients. Do they still go on olaparib on PARP inhibitors or not? What's the current practice?
Yes, so HDR patient or HRD patients, homologous recombination deficiency patients, are eligible for PARP inhibition in the maintenance phase after response to a platinum-based therapy. So you can see that we have different types of PARP inhibitors. We have niraparib that can be used alone in these patients, and we have the combination of bevacizumab and olaparib that can be used also in this indication. This is, again, now dependent on the designs of the clinical trials more than its dependence on the molecular mechanisms behind the mutations itself.
Great, Khalid. And let's remind Radwa and Amira and everyone here that after finishing the ovarian cancer module, the surgical part, we will have like 1 or 2 didactics about all the systemic treatment, including the chemotherapy and the maintenance treatment and the PARP inhibitors. So this was just an introductory lecture for that. Dr. Amr, do you have any questions or any comments?
Thank you, Doctor, for a very informative lecture. زي ما قلت حسب بداية الطريق إن شاء الله.
إن شاء الله. And we have Dr. Sarah Rubaish too. She's our dear friend and our dear guest from Saudi Arabia. Thanks for being here, Dr. Sarah.
Hello. Thank you for sending the invitation. You can hear me?
Yes, Sarah.
Yeah, thank you for sending the invitation. Actually, it's all the topic we're interested. And I love to join and learn more and more from the expertise. Thank you very much.
Thank you. It's always a pleasure to have you with us. And a final comment to Dina Farhat, because this is her first time to join us today. Dina Farhat is our dear medical oncologist from Oncology Center, Mansour University, and she has started joining us today. Does it work, Dina, to join?
Thank you, Dr. Basil. Thank you, Dr. Khalid. It was a great lecture, concise. يعني دي المرة الأولى إن أنا أشارك فيها بس it was great.
Thank you. Hope to see you on all the upcoming lectures. And let's remind all of you that after the permission of Dr. Khalid, we are going to upload this recorded presentation both on the EGOS website and the EGOS YouTube channel after the permission of Dr. Khalid for sure. And see you next week with the pathology of ovarian cancer with Dr. Amani Hassan. That would be a very nice and tough lectures that I hope all of you will be there next Wednesday, 9 p.m. with Dr. Amani Hassan. I believe most of you know her so much right now. Thanks, Dr. Khalid, for your time. Thank you so much.
Thank you, Dr. Basil. Thank you for all the colleagues.
And see you
Thanks,
soon.
Dr. Khalid, Dr. Basil. Thank you, guys.
See you.
Night.
Bye.
Bye.